Good evening, everybody. On behalf of Cardiology Society of India National Body and the Cardiological Society of India Chennai chapter, it's my privilege to welcome you all to this fourth consecutive days session on cardiac rhythm, which is called Cardiac Rhythm Council annual meet. This time it is on the digital platform. So thank you, audience. The response has been tremendous, and I wish that we all end up learning a lot of things because we have today four very illustrious um, cardiologists who are into the arrhythmia and heart failure therapies. And to begin with, we have our friend Dr. Abhishek Deshmukh, faculty from Mayo Clinic, who is going to be speaking to us. And to lead the moderators team, we have Dr. Vanita Arora, who would introduce the co-moderators and the speakers. And we start off with the first talk today with Dr. Abhishek Deshmukh. So I welcome the speaker and the moderators, and over to Dr. Vanita.
Thank you, Dr. Ullas, for this kind welcome and excellent job. I have to say this. I cannot stop myself from saying what you have done in past 3 days. This is the fourth session. Each and every session has been spectacular, and it shows all your hard work you have put in. Thank you so much for that. I have my proud privilege to introduce two wonderful EP faculties at the moment as the moderators. They will be joining me as the moderator for this session. Professor Dwivedi, who needs no introduction. Everybody knows he has so many students in line in EP and in intervention in the country. And Professor Nambudri from Trivandrum, who is, of course, our editor of IPEJ and a fantastic electrophysiologist. So I welcome you both to join me as the co-moderator for this session. To introduce the speaker, Dr. Abhishek Deshmukh is from Mayo Clinic. He is the co-program director of EP Fellows at Mayo Clinic, and his main areas of interest are ablation and device management in patients of infiltrative cardiomyopathies and adult congenital heart disease. He has authored more than 250 manuscripts, a lot of abstracts, more than 700 abstracts to his credit, and he's written chapters for more than 10 books. And he's also in the editorial board of JCE and the HRO2, the journal which has just been introduced. So welcome, Dr. Abhishek Deshmukh. We look forward to hearing from you about the EP maneuvers during wide QRS tachycardia in the lab. Over to you, Dr. Abhishek.
Thank you very much for the introduction. Am I audible now?
Perfect.
Perfect. Wonderful. So I'm going to talk about EP maneuvers during wide complex tachycardia. So our main learning objective today are to review the ECG criteria for wide complex tachycardia, evaluate the His bundle recording in wide
Excuse me, you may share your screen, please.
Yes. Can you see it or no?
Not yet.
Oh, sorry about that.
You have to share the screen. There is a green button there down.
Yeah. Is this better?
Let it come. Yes, now it is there.
Okay.
Not really.
Yes or no?
It's there now.
Okay, good. So sorry about that. So our learning objectives are review the ECG criteria for wide complex tachycardia, evaluate the His bundle recording in wide complex tachycardia, and finally we'll understand some of the very, very important maneuvers we do to sort out what the wide complex tachycardia is all about. So I'll start off with a case, and this is kind of like an audience poll, but feel free to chime in. For an 85-year-old female with a history of coronary artery disease presenting with palpitations and near syncope. So what is this going to be? Is it SVT with aberrancy? Is it VT, or is it antidromic reentrant tachycardia? So as you are thinking in your mind that older female with coronary artery disease, it could be multiple things, but more than likely maybe ventricular tachycardia, and you would not get faulted for that because the patient was actually managed as somebody having VT for a while. So we'll review some of the ECG criteria for wide complex tachycardia. So QRS, what happens during VT or ART or SVT with aberrancy is basically what the ventricle is making, what kind of signal a ventricle is making. So before we understand abnormal ventricular complex, let's look at some basic physiology of a normal ventricular complex. So the ventricular activation happens from apex to the base and from the endocardium to the epicardium. It also happens on the septum from left to the right. So that's why we have the septal Q waves in lead 1 and AVL. So whenever this is not there, then we start to think whether the ventricle is getting activated in an abnormal manner. Now, a clear diagnostic clue whether it is VT or not VT in a wide complex tachycardia, we look at VA dissociation, which turns out to be very specific. We look at capture beats and see whether it looks like any conducted QRSS. And then we look at fusion beats to know whether there is any intermediate morphology between the clinical wide complex tachycardia along with the sinus QRS and see if there is some fusion going on to again know whether there is VT or not. An easy trick is to look at the axis, and we all know by various criteria that if lead AVR is positive, then more likely that the patient is going to have ventricular tachycardia because just the axis is very, very unusual and abnormal. Another important tip is to look at the precordial transition. We know that there is a small R wave in V1 and a deep S wave. And as you go from V1 to V6, the R wave becomes taller and taller and we lose the S wave. Whenever you don't have this transition, we call it as an abnormal transition. So for example, positive concordance, meaning V1 to V6, everything is positive. So we start to think this is likely going to be accessory pathway or a very basal VT. Or V1 to V6 is all very negative. That means it's a very, very apical exit. So again, suggestive of VT. So any change in the precordial transition, then we start to think whether the QRS is generated against the grain of the normal transition of QRS. We also look at the terminal slopes. And again, if it is a little bit slurred, we start to think it is VT, and it is very brisk. We start to think whether it is some sort of SVT with an aberrancy. So putting it all together in this ECG, what I showed you, the positive, sort of positive concordance, at least up to V5, axis is very funny. The patient has coronary artery disease. She's in an older age group. So if you're a betting person, so, you're going to call it ventricular tachycardia. However, when she was brought to the lab with pacing from the coronary sinus, it turns out that she actually had antegrade conducting accessory pathway from the left free wall. So even at the age of 85, she had a very robust antegrade conducting pathway with no retrograde conduction. So that's why her ECG was looking that way. Plus, at very fast heart rates, whenever she would go into AFib, her AV node would get blocked consistently, and so there was no fusion going on, and all the QRSs were looking identical because of block in the AV node. So then, how to sort this out? Well, certain rules have exceptions and exceptions have rules, and no better than all of us in cardiology and specifically electrophysiology would know that. So we put together a good review on various wide complex tachycardia differentiation and how to sort these things out. And we go over many, many maneuvers and many clinical ways with some strengths and some limitations of each of these algorithms. But it's very important to know that all these algorithms are for VT versus SVT with aberrancy. And there is really no algorithm for VT versus antidromic reentrant tachycardia and for SVT with aberrancy versus fascicular VT. So again, very, very important to know that when we are applying all these algorithms, it is to differentiate VT versus SVT with aberrancy, and really no algorithm to look for VT versus antidromic reentrant tachycardia and SVT with an aberrancy, SVT with aberrancy versus a fascicular VT. Now, why that is true? Because we all know that the pathways get inserted on the annulus. So if you have an accessory pathway located here, the first part of the ventricle to get activated is going to be somewhere here, very basal, very lateral on the mitral annulus. So when the ventricle gets activated here, that's the time we get a QRS, and that's why, because it is so basal, we see all the positive concordance, what we see in a left free wall accessory pathway. If, however, there is also a VT going or exiting from this part, so mitral annular VT, the QRS is going to look exactly the same. So that's why in a patient with a pre-excited tachycardia or a ventricular tachycardia exiting around at the same place, it's really on ECG very, very difficult to know whether it is truly an ART or is it truly a VT. Clinical clues may help, like I showed in this case, like an older female, coronary artery disease, more likely to be VT. But again, younger patients can definitely have annular VTs in patients with a structure in normal heart. So important to know that when you see a wide complex tachycardia without any aberrancy, then you have to really go on with a very open mind and sort these things out to know what this all could be. Now, how to sort this thing out would be to evaluate the His bundle recording in a wide complex tachycardia. So separate story, 37-year-old young lady with long-standing palpitations presents with this type of tachycardia. So again, we'll spend a minute here. So left bundle branch block kind of transitions around V4, V5. Axis is fine, and 2, 3 AVF are sort of positive. So, we will have various differential diagnoses for this. But the first question, is it VT or is it SVT with aberrancy? And at least based on the P waves, what I could note, there was no VA dissociation. So again, all bets are off, and it could still be either of them. So when we look at a left bundle branch block tachycardia, a differential diagnosis, it could be an SVT with a left bundle branch block, SVT with pre-excitation over a right-sided accessory pathway, including a Mahan fiber, antidromic tachycardia using a right-sided accessory pathway, right ventricular tachycardia, like an RVOT tachycardia, will look very, very similar to what I just showed, or a moderator band VT. So RVOT, instead of RVOT, I would say more of a tricuspid annular tachycardia, because again, if you go back to this ECG, your AVR and AVL are going in the opposite direction. So for an RVOT, both will be negative. Because AVL is positive, this is not going to be an RVOT tachycardia. So when the patient has this and he comes to he or she comes to the EP lab, the first thing what we do is place catheters. What we're very concerned about is that we should not bump the accessory pathway. So we put this catheter, but make sure that if you're putting in a multi-electrode catheter in the right atrium, the tip has to be very, very free, maybe even in the ventricle, so that you're not bumping anything on the annulus. The key thing to note in the RAO view here, that the catheter is very anterior to the coronary sinus catheter. That again is important, because if the catheter is too posterior, then you're going to record a lot of crista terminalis signal, which are going to look like double potentials, and it then becomes very confusing to know whether it is truly a pathway potential or is a fragmented atrial signal or what all. So try to put the catheter more anteriorly, and then you can sort it out. Once you have it, we start to pace. So as you're pacing, you can clearly see atrium getting activated to the ventricle through the His bundle. As you keep on increasing the rate, you would start to see some changes. But mind well, we are also seeing this funny His bundle type signals on our annulus catheter, and we'll come to that. So as you keep on pacing, the activation sequence slightly changes, the QRS becomes much more wider, and now the His, which was getting activated in an antigrade direction, starts to get activated in a retrograde direction. So that's your clue that something is missing here, something is definitely different going on, and we need to sort this out a little bit more clearly. With maximal pre-excitation, we are able to see even more distal to proximal activation of the His bundle. So, we are now pretty much sure there is probably an accessory pathway going on, inserting on the right bundle, maybe like an atriovesicular pathway. Why this is important to know, because the His bundle is going to tell you your HV interval. It's going to tell you whether the His is getting activated in an antigrade versus retrograde direction, or if the His is truly a driver or just a bystander in this whole paradigm. So how to sort these things out would be to look at the sequence. So if you have an SVT with tachycardia with a left bundle branch block, you know that the activation is going from the AV node His and goes all the way to the right bundle. And your activation on the His is going to be proximal to distal with a nice HV interval. Sometimes what can happen is that if you have a very proximal right bundle branch block, and if the proximal electrode is beyond the beyond the site of bundle branch block, then the activation can go down the left bundle and then climb up the right bundle. So you may get sometimes a distal to proximal activation. So when something is amiss that way, you have to be very, very careful and make sure that the His bundle catheter is placed in the right direction. So in our patient, however, the activation sequence clearly changed. So we know that probably the His bundle catheter was placed at the right location. Clue is also to look at the atrial signal in the proximal His to make sure you truly see an atrial signal. How about for retrograde activation of the His? So you may have an ART coming down the atrium, going down the pathway, touching the right bundle, climbing up. But if you have a distal right bundle branch block, then the activation is going to go transeptal, climb up the left bundle, and then go down the right bundle. So in that case, although you may have an atriofascicular pathway inserting on the right bundle, your activation is still going to be proximal to distal, and that's your clue that you have a distal right bundle branch block. So some clues to think of. So whenever you have anything funny, make sure you look at location of the catheter and make sure whether there is presence or absence of a retrograde right bundle branch block. Now, whether His is a driver. So again, a typical example during V pacing, you induce this 3 beats of tachycardia, ventricular tachycardia, but clearly you would see here that the His to His is driving the V to V, and that is suggestive of a bundle branch reentry tachycardia in a left bundle branch block pattern. So know who is the driver and also know who is the passenger. So for example, here you have a pathway to pathway tachycardia and a complex tracing, but you have a wide complex tachycardia, becomes narrow and then becomes wide complex again. But the His signal, it is just marching out. So again, suggesting that the His is just a bystander His here. It is not participating or not getting activated in this tachycardia. So when you start to look at wobble, when we start to look at things changing in the tachycardia, we really need to know who is the driver and who is the passenger. So if the His to His is driving the tachycardia, it's ABNRT, JT, or bundle branch reentry. If the V is the driver, then it is VT. If A is driving, then you have to see whether the A is driving the H and the V together. If the A is driving the H first and V, then it has to be some sort of atrial arrhythmia with aberrancy. However, if the A is driving the V without affecting the His, then start to think you have either some sort of atrial arrhythmia with a pathway or a pathway to pathway tachycardia. So by now we have figured out the ECG, we have put catheters, we know how the activation is going. And now the next step is to really find out by maneuvers what are we going to call the antegrade limb of the tachycardia, and what we are going to talk about the retrograde limb of the tachycardia. So antegrade limb of the tachycardia can be sorted out by PACs, and retrograde limb of the tachycardia can be sorted out by PVCs. Fairly straightforward. You know, sometimes it becomes a little complex to understand, but just reverse the situation. So the same concept we use in narrow complex tachycardia, where we put PVCs and PACs, the same construct is here in wide complex tachycardia. By doing these maneuvers, we are trying to sort out what is the antegrade limb and what is the retrograde limb. So PACs in tachycardia, single most powerful maneuver, which is going to tell us, you know, what is the antegrade limb. So the technique here is that if you have a left free wall pathway, put the PACs from the left side. If you have a right free wall pathway, put a PACs from the right side. But make sure there is a recording or a sensing catheter on the septum at the AV node, because you want to see by putting in these PACs what happens to the AV node. At least in 2020, we don't have a catheter to record the AV node signal. So the next best surrogate what we have is the septal A. So pace from the free wall, but look at what happens to the septal A. So what we are going to do or trying to accomplish with a PAC maneuver is, first step is the atrial capture. Second, does the tachycardia terminate? Third, is the ventricle advanced? Fourth, if the ventricle is advanced, does it advance the next atrium? Next, does the septal A get advanced or affected? And then based on this, we know what's going on. And then finally, does the activation sequence change? So I'll go through this little bit slowly and step by step again. So you have a wide complex tachycardia, you put in a PAC, and boom, the tachycardia terminates. So great, the tachycardia terminates, but it terminates without affecting the septal A. So that means it did not go into the AV node to terminate the tachycardia. So it must have terminated the tachycardia somewhere else. And where is somewhere else? Has to be the accessory pathway. So if the PAC terminates the tachycardia without advancing the septal A, without going to the ventricle, it has to be an antidromic reentrant tachycardia for an antegrade limb of the tachycardia. Again, crucial measurement here is to make sure that the septal A does not get advanced. Because if the septal A gets advanced, then we know that the PAC is penetrating into the AV node, and we still can't be sure whether it is a bystander or not a bystander as far as the pathway is concerned. Next, in say a right free wall tachycardia, you are putting in a PAC. So again, right free wall tachycardia, we're going to put a PAC from the right free wall. And then what happens? You advance the next V, you also advance the next A and reset the tachycardia. So PAC is put in. So the tachycardia is going at 287 milliseconds. You put in the PAC, the next V gets advanced at 270 milliseconds. That also advances the next A with the same amount. So you know that the antegrade limb has to be going down the pathway. So let's think about it a little bit more. So you have a PAC, you have a tachycardia going on. So atrium going down the accessory pathway, climbs up the ventricle, right bundle, ventricle, goes up to the AV node, goes back to the atrium. We put in a PAC, the septal A is not advanced or changed. That means that PAC is not going to the AV node. But what it did, it went down the accessory pathway. So because it went down the accessory pathway, the ventricular signal is advanced. The first step to see if the QRS has changed. If the QRS has changed, then there is fusion. But if the QRS has not changed, that means it is going down that same accessory pathway. It climbs up the right bundle and then goes up the AV node and goes back into the atrium. So that's why the next A becomes advanced as it climbs up the AV node. So that would reset the tachycardia. So now you know that the PAC did not advance the septal A, advance the V, no fusion, climbed up, advance the next A, and that is your clue that you have ART with pathway participating in the tachycardia. So again, just as in a video, you have wide complex tachycardia going on, and then again, right free wall pathway, 330 milliseconds, and we put in a PAC from the right atrium here, and that doesn't advance the septal A. So this is your PAC, doesn't do anything to the septal A yet, but it advances the next QRS. The QRS looks the same, and then it advances the next A. That means it went down the pathway, advanced the V, climbed up the AV node, then advanced the next A. That is very, very suggestive of ART and ART participating in the tachycardia. How about with the bystander pathway? What's going to happen? So same construct, you have an AVNRT going on, and sometimes the activation is going down an accessory pathway. You put in a PVC, you put in a PAC, that the PAC goes down the pathway, but because there is two ways by which the ventricle is getting activated. One is your AVNRT going down going down the normal His-Purkinje system and your accessory pathway. You may start to see fusion. Even if you don't see fusion, if the V is advanced as it climbs up, the next septal A does not get advanced because the AV node is refractory because of the primary tachycardia going on in the AVNRT. So that would be your clue that you have tachycardia going on with accessory pathway as a bystander. So septal A does not get advanced, so the activation goes down the accessory pathway. And when it climbs up, the next A is not advanced. So that means the tachycardia is not reset. So if no reset, you are dealing with a bystander accessory pathway. Similarly, with ABNRT with a left bundle branch block, what's going to happen? You may have tachycardia going on in the ABNRT thing. You have a left bundle branch block. You put in a PAC. The septal A is not advanced again because it is refractory due to the ABNRT. Tachycardia is not advanced. So again, consistent with ABNRT with a left bundle branch block tachycardia. So let's see this example again. You have tachycardia going on. You put in a PAC. So what the PAC is going to do, there's no pathway, so it can't go through any accessory pathway, but it may advance the next septal A without changing anything to the tachycardia. So the next septal A gets advanced. That means the thing is going into the AV node, and it may terminate the tachycardia at times, but a lot of times it doesn't do anything to the tachycardia. QRS doesn't change. So that means there are no two ways of going to the ventricle. So it has to be some sort of SVT, ABNRT with an aberrancy. Now what's going to happen in VT? So in a VT, you're going to have a ventricle which is firing from somewhere here. Again, a left bundle branch block tachycardia. You're going to put in a PAC now. But again, if the PAC is going to go down to the ventricle, even if it goes to an accessory pathway or an AV node, you're going to have fusion because of two wave fronts, one coming from the atrium, one going from the ventricle. You're going to have some sort of fusion. Also, your septal A is going to get pre-excited because it can go down the AV node. And because of the fusion, you know that this is not going to be an ART. This is more likely to be VT going on. And again, if the septal A is advanced, you have fusion, more likely going to be VT. But again, you're going to have a whole day to try to figure it out because you may have AV dissociation. You're going to have a lot of things.
Sorry for the interruption, sir. There's just 2 minutes of the screen time left.
Yes.
Thank you.
Yes, I should be done shortly. So it is very, very important to know, what changes and if there is any fusion. So simplified maneuver, PAC advances the V without advancing the septal A. It advances the V without advancing the septal A and resets the tachycardia. Think it is ART. PAC advances the V and without advancing the A, and the next A is advanced. Then, although we have made a diagnosis of ART, as really astute electrophysiologist, you may also figure out what is the retrograde limb. So if the A is getting advanced without advancing the retrograde His, then think it is a pathway to pathway tachycardia because the retrograde His is not participating in the tachycardia. So advancing the A, but A is getting advanced much more compared to the retrograde His, think pathway to pathway tachycardia. You're advancing the A along with advancing the retrograde His with the same magnitude, think the retrograde conduction is going over the AV node. So very, very simple concept here. PAC, see what gets advanced. Is it the V? If the V is getting advanced, see if the septal A is getting advanced. If the septal A is getting advanced, think there might be something going on around the AV node. But if the septal A is not getting advanced, then look for fusion. Look for if the next A is advanced. If the next A is advanced, then see how much is the A advanced. And if the magnitude of A being advanced is similar to the retrograde His, if the magnitude is much more compared to the retrograde His, pathway to pathway tachycardia, magnitude is not, or the magnitude is equal to how much the retrograde His is advanced, think that the retrograde conduction is going down the AV node. But again, for figuring out the retrograde limb, as EPs, we have all day to do this. You can always ablate the antegrade limb, then do your parahischian, then do ventricular pacing, and that is also going to tell you what the retrograde limb is going to be. Now, we figured out the retrograde limb. How about we figured out the antegrade limb? We also could figure out the retrograde limb with PACs, but how about with a PVC? So again, you have a wide complex tachycardia going on. Cycle length 292 milliseconds, and then here you put in a PVC. You put in a PVC, and then the A gets advanced much more than what the His could get advanced. So A is getting advanced much more than what the His could get advanced. So that means that the retrograde activation is bypassing the AV node or His bundle. So there has to be a second pathway which is present. So again, a useful maneuver. But by this time in a case, you would be able to figure out what is the retrograde limb of the tachycardia. But again, important to delineate antegrade limb, retrograde limb. Sometimes if it is confusing, ablate one of the limbs and then sort out what's the other limb which is remaining, and that can be targeted for ablation. So in conclusion, really there is no algorithm to differentiate ART versus VT. So we have to put the clinical context in picture, but beyond the clinical context, we have to really look at some of the intracardiac things what we went around, we reviewed. Understand the importance of a good His recording, look at the HV interval, look at the activation sequence of the His, whether it is antegrade versus retrograde. Look for sudden changes in the HV or VH interval. That's going to tell you whether a retrograde right bundle branch is present or absent. PAC maneuver is critical, will help you sort out, what is the antegrade limb. And again, you have to do it by figuring out who gets affected first. Is it the septal A? Is it the V? If it's the V, there is fusion? If there is no fusion, does the next A get affected? If the next A gets affected, how much does it get affected compared to the His? And that's going to tell you what is your antegrade limb, retrograde limb, and you're going to sort out whether it is AVNRT with a left bundle branch block or a true atrioventricular reentrant tachycardia or a pathway to pathway tachycardia. And again, practice this maneuver often even in a patient who does not have this tachycardia going on, because then at least your mind is going to get tuned in to what you're looking for. I think I'll stop here and thank you very much.
Thank you, Abhishek. It was actually a very elusive and a beautiful presentation. And I really appreciate your analogy, his participation analogy as a driver or as a passenger. I will use it more often now. And I would request Dr. Dwivedi to please come in, and Dr. Namudri to please come in and take the discussion forward. I think there are some the question on the chat also. Dr. Dwivedi, if you could please address it, sir.
Yeah, it was a wonderful presentation. I think you had explained everything from basic concepts like VA dissociation to complex maneuvers involving PAC and the changes in his timings, everything. So there is only one question from the audience, as I can see.
Correct.
This is from Dr. Shaktivel. What is the difference between a septal refractory PAC and a His refractory PAC? I think he didn't mention PAC. Assume it is PAC because he had included septal refractory. So are they interchangeable? Is the question for you?
That's a good question. So, when we think of septum, we are when we are doing the maneuvers, ideally we really want to see what happens in the AV node. But unfortunately, we don't have any way to measure what happens in the AV node because we are not able to record any AV nodal signal. So the surrogate what we use is some sort of atrial signal on the septum. So whenever we use septal refractory or His bundle refractory, we are trying to see whether we are actually refractory to the AV node. So, it can get used interchangeably. We don't use the AV node refractory because we truly don't know whether the AV node is really refractory because we don't have a signal there. So the surrogate what we use is septal A or septal A refractory.
Yeah.
Excuse me, Dr. Yash Lokanda's question.
Yeah, there is another question. Yeah.
Yeah, it's a comment rather. When you have an atriovesicular pathway mediated tachycardia and you give an PAC, in fact, when you have a shift of this limb, the retrograde right bundle branch block, if you have a transeptal conduction, instead of advancing the next A, you can even have a prolongation of the next. That is one comment by Dr. Yash. It is a theoretical question, theoretical scenario that he has mentioned. And also in that, just to add to that, probably when you have a PAC giving at that point in time, because of the decremental characteristic of the pathway, you can even have a prolongation of the AV interval rather than advancing.
All those things are.
There is another comment from Suchit. It is different.
No, Dr. Dwivedi sir, I think Abhishek, you please take over that Yash's question. It was quite theoretical, but there's a lot of science behind it. We will go over with Yash's question, please.
So I think that's a great point. That if the sometimes if the VA interval change, you want to see what changed the VA interval. So the VA interval can change for two reasons. Either you go up through a decremental accessory pathway, again, rarest of rare possibility, but can happen. But more common that you could get a retrograde right bundle branch block. So instead of climbing up the right bundle, it goes transseptal and then climbs up from the left bundle. So that is going to prolong your VA interval. The key thing to know is what is driving again that VA interval. Is it the VH or is it beyond the VH? So if the VH is driving that VA interval, so that means something happened in the retrograde activation in the bundle branch blocks. Same concept can be applied for left-sided free wall accessory pathway, and you get a left bundle branch block. Again, the VA can get prolonged because the VH prolongs because of retrograde left bundle branch block. The activation is going to go over the retrograde right bundle. But the key thing when this happens is to find out what prolongs, and if the VA prolonged, is it related to the VH prolongation? But certainly can happen, and actually happens quite a lot, and it's a nice thing when they ask on boards and exams and everything.
Now there is another comment. It is difficult to see his in antidromic tachycardia. Any technique to give his refractory PVC?
So it is, you're very, very right, and it is very hard to record his. The couple of clues would be to have a multipolar closely spaced catheter. You can even consider putting two catheters, but the reason it is hard to see his beyond the recording technique is that the HV is almost zero or sometimes negative. So that his signal actually gets buried in the QRS. So the technique would be, again, when you start playing with PACs and PVCs, you want to see whether you could pre-excite or post-excite that region to bring out the H. So that would be the way to do it. And then the second question was again, septal A something, right?
Yeah. That is septal refractory PAC may advance V, but find right bundle in a refractory state and go up left bundle. That you have already discussed. Another question is by Dr. Ramdev Yadav. How will you differentiate in AVNRT with aberrancy with left bundle branch block aberrancy from bundle branch reentrant VT?
That's again a very good question. So AVNRT with left bundle branch block versus bundle branch reentry. So whenever you're doing your maneuvers and the way the tachycardia is going to get initiated, you'll have a jump and going up the fast pathway and all that. What would be your clue? The main clue is that you have to figure out if there is wobble going on, what is driving what. So again, HH is going to drive the VV. That would be true for bundle branch re-entry. AB dissociation is a very powerful clue because in bundle branch re-entry, again, you may have AB dissociation. But the most important clue would be your HV interval. Your HV interval is going to be same in sinus rhythm as well, along with the sinus rhythm has left bundle branch block, along with an SVT with the bundle branch block. But in bundle branch re-entry, it can be very long, it can be very short, or it could be the same again because of depends on where it is turning around. But then maneuvers are going to help with your pacing maneuvers are going to help your his synchronous PVCs, ventricular overdrive pacing. All those maneuvers are going to help to figure out the diagnosis.
So I think, Vanita, that was a great session. Thank you very, very much for moderating this session so beautifully. Divedi sir, so very thankful to you. Nambudri, as usual, your inputs were great. Abhishek, thank you very, very much. You have been always supportive of the Indian EP program. Thank you very, very much. So ladies and gentlemen, I would like to announce here that the registration count has reached now 900 and there are 310 active participants. That's great news here. And maybe there are topics here today. They are really very interesting. For example, the next topic is going to be addressing something which causes, I believe, nervousness and some anxiety or hesitancy among the cardiologists. And that is the usage of a newer molecule, SGLT2 inhibitor in heart failure therapy. We have Manoj, one of the very accomplished interventional cardiologists of the country. He's going to be speaking on that, and Dr. Shanmuga Sundaram would lead the group of the moderators, Mohanan sir and Ajit Mullasari sir. So over to Dr. Shanmuga Sundaram, who happens to be the past head of the Department of Cardiology of the prestigious medical colleges in the country, and that's the Madras Medical College. Shanmuga Sundaram, sir, it is honor for the Cardiology Society of India and the Cardiology Society of India Chennai chapter to welcome you as a moderator for the second session. Over to you, sir.
Thank you, Dr. Ulas. Good evening, dear friends. And this is going to be an important talk now. The role of SGLT2 inhibitors in management of heart failure. We do see off-target effects of many medications. To quote one, amiodarone, which was introduced as an anti-anginal drug, becoming an effective antiarrhythmic drug. Something similar to it, we have a molecule which came to diabetologists first, and now we have the privilege of using it much more than the diabetologists. To speak on this important issue, I have my friend, Dr. Manoj, who is an interventional cardiologist from Kaveri Hospital, Chennai, to talk on this important topic. Dr. Manoj is a product of Calicut Medical College. All of his classmates in medical school are still angry with him because he has not left even a single medal to share with any one of them, right from anatomy to obstetrics gynecology. After his brilliant career in medical school, he had moved to Sri Chitratirunal for his cardiology qualification. Then came down to Chennai, worked in many places. Now he is an active interventional cardiologist at Kaveri Hospital. It's quite unusual for an interventional cardiologist to talk on something on preventive cardiology. Dr. Manoj is very good at it. I think next to interventional cardiology, his passion is for heart failure management. I think Ulas has chosen the right person to talk on this. Dr. Manoj, over to you.
Thank you, sir. I hope you are able to hear me and also see me and also see my slides.
Yes, very much.
Thanks, Ulas, and all the organizers of the CSI, CRHM for this invite for addressing on this topic. And esteemed chair, Dr. Shanmuga Sundaram, Dr. Ajit Malasari, and also dear my friends. It's a pleasure to address on this very hot topic, which is being discussed in and out, and particularly in the ESC 2020. So I would be focusing on the topic of SGLT2 in heart failure with reduced ejection fraction management, when and how. Even though the topic was on heart failure, we know certainly that heart failure also comprises of HF also. So I'm not going to touch on the HFpEF because we still need some data more on the HFpEF, which we still remains elusive in the management of HFpEF with a multitude of drugs, and it's a totally different matrix of etiopathogenesis in HFpEF. So it will be on HFrEF. We certainly know that the heart failure is a progressive serious disorder in cardiac condition with an increased high mortality, and also has repeated episodes of acute decompensation. And you would see that multiple decompensations reduces the quality of life as well as increase in mortality. So when we talk about the heart failure, one has to look at the mortality, worsening of heart failure, and also the reduced quality of life parameters in assessing the outcome of heart failure management. So cardiovascular disease is most prevalent cause of mortality and morbidity in diabetics, and 2/3 of deaths are attributed among the diabetics to cardiovascular disease. We also know shortly about a few years back, about not so long, about 6 years back, that in a larger cohort of 1.9 million with patients with type 2 diabetes and no evidence of cardiovascular disease at baseline, followed up for more than 2 decades, and looking for the incidence of cardiovascular disease presented by Shah, we knew that the heart failure was the first manifestation of cardiovascular disease in diabetics next to peripheral arterial disease. However, in all the trials that we knew all these years, the myocardial infarction and stroke continued to be the primary efficacy endpoint in the major diabetic management trials. And so the heart failure, which we know that macrovascular complications, myocardial infarction, stroke, peripheral arterial disease, among the diabetic associated complications, along with the microangiopathies, the heart failure, which is most frequent manifestation and most fatal outcome, was seriously forgotten in all the trials. So the Trivandrum heart failure study showed that 55% of patients hospitalized for heart failure had diabetes mellitus as well. So about 45% had no diabetes mellitus. A unique class of drug, the SGLT2, the sodium glucose linked transport receptor 2 inhibitor, acted by promoting glycosuria, was newly introduced for glycemic control along with the standard of care medications in diabetes mellitus. As mandated, many trials were initiated to understand the cardiovascular outcome of these varying SGLT2 agents. And then came the change of turning point. And these are the meta-analysis of SGLT2 on the major adverse cardiac outcomes. If you see with those with established cardiovascular disease, you would see in the pooled analysis about 40% relative risk reductions with diabetes with an established cardiovascular disease using SGLT2. Whereas diabetics without established cardiovascular disease and only with multiple risk factors, they did not have any beneficial response with regard to the major adverse cardiac events with the continued use of SGLT2. If you look at the SGLT2 with regard to the heart failure management or onset hospitalization of heart failure, and the previous history of heart failure was present, and there were some populations varying from 10 to 30% in all these groups of meta-analysis of these major randomized cardiovascular trials with SGLT2. You would see that 32% relative risk reduction of hospitalization for heart failure, even with those who had a history of heart failure at baseline enrollment. And those with multiple risk factors and no established cardiovascular disease also had a 29% relative risk reductions. So regardless of whether they had an established cardiovascular disease and they had only multiple risk factors, or they also had a history of baseline heart failure, all groups of patients with diabetes mellitus receiving SGLT2 had significant reduction of heart failure hospitalizations. So this is a meta-analysis looking at whether they have a heart failure or no heart failure or a prior heart failure in all these CANVAS, declared TIMI, and EPIREC outcome. You would see that all had a favorable outcome favoring SGLT2 inhibitor use for reducing the heart failure hospitalizations. We all know traditionally and conventionally, all of us use ACE inhibitors, ARBs, RNI, MRA, and beta blockers for their and MRAs and ivabradine for their known beneficial standard class of recommendations of class 1A for reduction in the morbidity and mortality. Let's look at the intravascular compartment as well as the interstitial compartment fluid shifts with the use of SGLT2. You would see that the interstitial edema is very, very significantly seen in the myocardium as well as in other tissues of the human body in congestive heart failure. What the SGLT2 does, it significantly brings down the interstitial volume without much affecting the intravascular volume as compared to the loop diuretics, which predominantly reduces the intravascular and causes volume contraction, but also later on there is a fluid shift and there is an interstitial volume. Whereas SGLT2 predominantly brings down, even from the beginning of its use, the interstitial volume, which significantly translates into myocardial important improvement in the kinetics as well as energetics. So in 2019, the various cardiovascular outcome trials with SGLT2 showed that there was a robust effect of this newly introduced SGLT2 inhibitors in reducing the risk of heart failure outcomes and also the renal outcome, and that does not appear to be dependent on the baseline atherosclerotic risk factors or a baseline prior history of heart failure or their renal functions. And therefore, ESC and EASD, the class 1 level of evidence A guidelines recommendation came in 2019, showed that SGLT2 should be used to lower the risk of heart failure hospitalization in patients with diabetes mellitus. So what was not known until now, we certainly know that it does reduce the development of heart failure in patients with type 2 diabetes mellitus, but we were exploring whether they can be used to treat patients with established heart failure, and there were some clues as we show from the previous meta-analysis. Also, what we known was whether the SGLT2 inhibitors can be used with the same benefit in heart failure management in those who did not have diabetes mellitus. So SGLT2 inhibitors added to the standard care of therapy for heart failure with reduced ejection fraction with or without diabetes was put to test in 2 major multi-center randomized trial, and one is the DAPA-HF, and other one is the Emperor heart failure with reduced ejection fraction. So the DAPA-HF was presented in 2019 November, not so long back, about 10 months ago. 4,700 patients spread over 20 countries were randomized 1:1 to receive dapagliflozin 10 milligram versus placebo in those with class 2 to class 4 heart failure and less than 40% ejection fraction, and in those with sinus rhythm to have maintained a pro-BNP of more than 600, and those in atrial fibrillation more than 900, and they were followed up at every 30 days interval and to look at the primary composite endpoint, which was cardiovascular death, heart failure hospitalization, urgent heart failure hospitalization visit. And you could see that there was significantly elevated levels of NT-proBNP, indicating that they were continued to be in heart failure, and ischemic etiology was predominant, being in the diabetic population as well. And about 45% of patients were diabetic and 55% didn't have diabetes in DAPA-HF. So you would also see that the all standard of care therapies, 94% received ACE, ARB, or RAS inhibitors. Beta blockers were used in 96%. MRA was used in 71%, which is the most remarkable standard of care and optimal heart failure management, over which the drug dapagliflozin was used. And the primary composite endpoint, you could see that there was a significant reduction to the extent of absolute risk reduction of 4.9% and relative risk reduction 26% in the primary composite endpoint of cardiovascular death, heart failure hospitalization, urgent heart failure visit to the hospital. And these were shown with a number needed to treat was just 21, and the effects were seen with the dapagliflozin much early, within few days of starting the therapy. And you could see the curve started diverging significantly with the time of use of this drug and exposure to this drug. When we split into these components, you will see the heart failure, worsening heart failure was reduced by 30% with an absolute risk reduction of 3.7%. Cardiovascular death came down significantly by 1.9% absolute risk reduction and the relative risk reduction of 18%. So the secondary endpoint, the all-cause mortality, also was significantly lower in those receiving the study drug of dapagliflozin with an absolute risk reduction of 2.3% and a relative risk reduction of 17%. Cardiovascular death and heart failure hospitalization combined endpoint was also significantly lower by 21%. And there was no safety concern of any kind with the use of dapagliflozin in this high cardiovascular subset with those with heart failure. No serious adverse effect, including death, which was much less, significantly less in the study group with dapagliflozin. There was no significant increase in the urinary tract infections, nor genital infections, or the discontinuation rate was very minimal in the study group with dapagliflozin. So let's look at the second question which was addressed, was dapagliflozin and heart failure in patients with didn't have diabetes mellitus. And you would see that in this population there was 2,600 patients, and you would see that compared to the diabetes who had 25% relative risk reduction in the composite endpoint, this consistent benefit was seen to the extent of 27% in those who didn't have diabetes, slightly better response in those who didn't have diabetes on the primary composite endpoint. Worsening of heart failure in diabetes was 23% risk reduction, and here it was much more amplified with 38%. So those who didn't have diabetes also significantly and even more favorably better outcome was seen in without diabetes. In cardiovascular death, 21% in diabetic relative risk reduction, and those who didn't have diabetes had 15% relative risk reductions. So you would see that in the slide, those who had diabetes or no diabetes, normal glycemic, pre-diabetes, there was an absolute risk reduction close to 4 to 5% in all the patients who had heart failure, regardless of whether they had normal glycemic, dysglycemic, impaired glucose tolerance, or diabetes mellitus. So this was the first trial, DAPA-HF, to show that heart failure without diabetes mellitus also was benefited significantly in the primary composite endpoint with the use of dapagliflozin, which was an important SGLT2 drug. The summary and conclusion in this DAPA-HF was dapagliflozin reduced the risk of worsening of heart failure, cardiovascular death, improved symptoms in patients with HFrEF when added to the good optimal standard of care therapy. Relative and absolute risk reductions was consistent in all those, even those without diabetes mellitus. It was well tolerated. Rate of treatment discontinuation was meager. Dapagliflozin thus opened and emerged as a new approach to the treatment of HFrEF along with the standard of care therapy. Then came the recent couple of days back published the Emperor heart failure trial with the effect of empagliflozin on cardiovascular and renal events in heart failure with reduced ejection fraction. The median follow-up was 16 months with 3,700 patients with NYHA class 2, 3, and 4, ejection fraction of less than 40% with or without diabetes on a standard of care management, as we already saw. There were much more sick patients in this population with a mean ejection fraction was 27%, and whereas in DAPA-HS it was about 30%, 31% precisely. Empagliflozin 10 milligram versus placebo given once daily, and the primary composite endpoint included composite cardiovascular death and heart failure hospitalization for worsening heart failure. And you will see that again the optimal standard of care was applied. There were better number of patients in this group with neprilysin inhibitor RNA, and together RAS was in 89%, mineral corticoid was 70%, beta blockers was 94%, indicating optimal heart failure management. You will see the primary composite endpoint was in favor with significant reduction to the extent of relative risk reduction of 25%, favoring empagliflozin on the cardiovascular death and heart failure hospitalization. The composite renal endpoint also came down significantly by 50%. So in the nutshell of the Emperor reduced ejection fraction, the primary endpoint of composite cardiovascular death and heart failure.
Sorry for the interruption, sir. 2 minutes
Yes.
screen time left. Thank you so much.
I would finish in a minute time. 25% relative risk reduction. First secondary endpoint was heart failure came down by 30% relative risk reduction. Secondary endpoint, the renal outcome was reduced by 50%. So you would see there was no significant safety signal on the cardiac worsening or worsening of renal functions in those who did not have even worsening CKD with diabetes CKD. So compared to the Emperor and the DAPA-HF, you would see that the DAPA-HF had a mean 31% ejection fraction, whereas Emperor had 27%, indicating more significant heart failure patients, reflecting even higher levels of NT-proBNP as compared to those in DAPA-HF. GFR rate was significantly lower as compared to the DAPA-HF. The RAS inhibitor and neprilysin user was almost double than in DAPA-HF. So these reflected some of the differences between the trials. The SGLT2 trial meta-analysis combined both, looked at, which was published 2 days back, but looked at the primary endpoint of this meta-analysis of 8,400 patients to look at the cardiovascular death and all-cause mortality, and showed that the all-cause mortality came down by 13%, and cardiovascular death was reduced by 14% relative risk reduction in both the groups of patients with heart failure with reduced ejection fraction. And the effect of empagliflozin and dapagliflozin on heart failure with reduced ejection fraction reduced all-cause as well as cardiovascular. In the interest of time, I'll just move in. This was the important 5 pillars in the management of heart failure with reduced ejection fraction. You had AC, ARB, RNA, beta blockers, MRA. Now you have dapagliflozin, empagliflozin, and perhaps we would know that it would be the SGLT2. So to conclude, I would say the Emperor reduced heart failure and DAPA-HF trials will have a major impact on the management of heart failure with the chronic heart failure with reduced.
I think we lost the connection with Manoj. I think there has been a technical glitch. That's it. Shanmugam Sundaram, sir, I think you should take over now. I think he was coming to a last slide of his. So Ajit sir and Mohan sir to give company to Dr. Shanmugam Sundaram, I think is an important topic. Even though I could not actually get when and how, maybe I think we should focus on that part of the talk.
Maybe I can request my co-chairs, Dr. Ajit and Mohan, to lead the discussion.
Thank you for the opportunity, everyone. And Manoj did a very creditable job, and it was a very erudite lecture. We know now SGLT2 is becoming a cardiologist drug. It's true also that we cardiologists see more diabetics now in our country. So possibly this is, the little confusing thing which has happened was when we look at the DAPA-HF trial and also compared it to the Emperor reduced, the reduction of mortality that you have seen in the DAPA-HF was not reflected in the Emperor reduced. And we could attribute Professor McMurray in the ESC TV was just trying to compare these two trials and say that maybe because, of course, as Manoj alluded to, this possibly where we may need more number to get the real reasons. So we may possibly see more number of SGLT2 trials. But the one thing is very certain, we have a very potent drug in our armamentarium now, which produces tremendous benefits along with the other 4 pillar or 3 pillar or 4 pillars. Ajit?
I think I'll take the 2 questions which have been chatted. One is, can EMPA be given to senior citizens older than 80 years old? Unfortunately, both the trials didn't include these patients. So it will be difficult to talk about this group of patients, but I think we'll need to wait for a trial to look at this. The second question is by Dr. Ilayaraju. We had 4 molecules in this class. What is the primary mechanism that gives? I think it's a class effect. If you look at all the trials with DAPA, EMPA, and even with CANA, there seems to be a class effect here. But I think the mechanism, one is the interstitial edema coming down. And the second is a very important mechanism. If you look at the ESC chat this week with McMurray, he talks about a starvation type of issue. EMPA creates sugar loss and makes your body feel it's starved and completely resets the metabolism and makes the body react as if you're in starvation, and it creates all metabolism changes which protect the heart and mother tissues. So I think it's a very important thing we should understand apart from. Now, if you're on a loop diuretic, the next question is how to go with the dose of SGLT2. When you start with an SGLT2, remember that diuretic dose should be minimized because hypovolemia is a problem, because these will create many issues, including peripheral vascular problems. So you need to keep the patient on less diuresis and try to remove at least the loop diuretic as quickly as possible so that your heart failure issues with the SGLT2 are maximized. How do you measure LVF when LVF of 35 leads to many crucial decisions? Well, this is something which is very important, and I think more and more we are moving away from EF because it's such a sort of unsure way of measuring it. I think there are many indices which can be used now, which can be looked at the echo. The other thing, that's the reason why when you, in this trial with the Emperor HF, we were part of it, and we contributed to 8 patients in this study. And one of the issues they did was that the EF between 30 to 40, which is always a vague EF, we are not sure what it is. They used pro-BNP, anti-BNP for inclusion. So this is very important, I think, in the whole thing, what we should look at. Yash has said, any evidence by imaging that myocardial edema is reduced? I don't think these trials did that, but I'm sure there will be some papers on myocardial edema with MRI, which could possibly show it. And I think that's the benefit that patients with diabetes and no diabetes have in heart failure. I think this is an extremely important question. If you want choice between an ARNI and SGLT2, what is your first choice? I think ARNI has more studies when I'm not in the ICU, but immediately post ICU, you can start an ARNI quickly. But we don't have both the trials having SGLT2, either in the ICU or in the immediate ICU phase. So what I would think what will happen is after a diuretic which stabilizes the patient in the ICU, you'd possibly start a beta blocker and maybe ARB or ARNI, and then later on introduce an SGLT2, though the class of indications is pretty much good. EMPA and DAPA, which one would you prefer? It's a difficult choice. I think the 2 trials were designed differently, but the outcomes are more or less similar. And I think that end of the day, to put your money on these 2 trials, which is better, would be difficult. Even Dr. McMurray, who was a part of both the trials, couldn't put his money on it. So I think it's better to just say that this is a class effect. One good thing is we don't have to remember multiple doses. Both are 10 milligram. So we can remember this dose very simply and use that as a heart failure drug. I suppose I can just, Manoj is back, and I think Shanmusundaram and Dr. Mohan can take the next questions, please.
I think, we can wind up. I think Dr. Manoj hasn't joined back. Ulas, how about
back,
all right, you know what? Let me just say thank you, a big thank you, Dr. Ajit. You know, I think your summary was fantastic, and I think there is the most of the important questions. You replaced the main speaker very, very effectively. You know, he's giving glimpses and then he's disappearing. Manoj,
I have some connectivity issue. I hope.
No problem. Ajit actually had made us believe that we didn't miss you. So he covered it very, very well, and there were fantastic questions. You may go through the chat box there, but then I think we should do another session, which is the second session of the day. You know, the entire faculty for the second session is so very illustrious, and I'm so very proud to present to the audience Dr. Kamal K. Sethi, who is going to be talking on NOACs, and it would be moderated by the father of electrophysiology in the country, Dr. Khalilullah. He would be taking over the session. He would introduce Kamal K. Sethi and his co-moderators, Dr. Kannan, who happens to be actually the organizing secretary of this particular digital summit. And he's going to be ably accompanied by Dr. Elilan, my colleague at Madras Medical Mission, an accomplished interventional cardiologist and heart failure specialist. So over to Dr. Khalilullah to introduce Dr. Sethi and take the session forward.
Hello.
Yes, sir, we can hear you.
My video is not on. Video is not on. It says the host has stopped it. So can you?
No, sir. Nobody can stop.
We are able to see you, sir.
Now I can see myself. Thank you very much.
I can also see myself. Thank you, Ulas, for inviting me to this very important meeting organized by the Chennai branch of CSI. I am very grateful to you, as always. Before I start the meeting, can I take a second from you all?
Sure, sir. I mean, the entire session is yours. Please take it.
The best cardiology in the country are passing away. The national loss to all of us. Can we stay silent for 1 minute in our memory? Please do that. I'll be very grateful to you all people. So just a minute in silence with Dr. Padmavati.
Yes.
Hear me? Can you hear me, Ulas?
Yes, sir. Yes, sir. We are observing the silence as per your instructions, and it's a great tribute to her.
Okay. Thank you. Thank you. Now coming to the speaker, Dr. Kamal Sethi is one of the brightest students from the Maulana Medical College, GB Pant Hospital. He was professor of cardiology at GB Pant Hospital, received the coveted Padma Shri Award from Government of India. He is now the chairman and managing director of Delhi Heart and Lung Institute. He is also the patron of Indian Heart Rhythm Society. Please go discuss and deliberate on the topic of selection of NOAC. Dr. Sethi, please. Thank you.
Thank you, sir. Good evening, everyone. I need to share my screen here. Can you see my slides, please?
Yes, sir. Yes, sir.
Thank you. Good evening, sir.
Yes, we can.
It's always a pleasure to speak when Professor Khalilullah is in chair, because we have very fond memories. We learned so many things from him as students and also as faculty when we are all working in GB Pant Hospital. Now, what has been assigned to me today is something that has been talked about very frequently in the past, but nevertheless, I think is worthy of revision because one keeps forgetting these things. How do we choose amongst the NOACs for stroke prevention in atrial fibrillation? I think the basic issue here, whenever we use any anticoagulation, is to try to reduce the events, the stroke and systemic embolism, while trying to understand the risk of bleeding in a particular case and trying to keep that risk to the minimum possible so that we balance the benefits and risks of anticoagulation. Now, we have 4 NOACs available, out of which only 3 are available in our country till now, apixaban, dabigatran, and rivaroxaban, and all have been compared independently with warfarin. Now, it is important to understand the important differences between them. Apart from the oral bioavailability, which is the highest with rivaroxaban and minimum with dabigatran, and somewhere midway between the two with apixaban, most important thing in understanding this is their excretion, the renal clearance. And the easy way to remember this is 25% renal clearance for apixaban, 35% renal clearance for rivaroxaban, 50% for edoxaban, and about 85% for dabigatran. This is important because it helps us to make decisions in patients with chronic kidney disease, which is a very, very common accompaniment of diseases or comorbidities that these patients have. Otherwise, there are no major differences in safety and efficacy between different NOACs as far as treatment in non-valvular atrial fibrillation is concerned, but there could be some preferences among molecules and doses based on individual clinical features, risk factors, and comorbidities. And that is where I'm primarily going to focus my talk on. Oh, I'm not able to move further. It's stuck. So how do we move it? Yeah. Okay.
I think you are okay, sir, now.
Yes, that's right. Now, this talks about the relative effects of NOACs organized by the magnitude of reduction of stroke, systemic embolism, and the magnitude of bleeding that happens with them. Obviously, these are not direct head-to-head comparisons, so these are observations based on the individual randomized controlled studies. Now, here is stroke and systemic embolism reduction on the left-hand side that you can see is highest with 150 milligram dabigatran given 2 times a day. Apixaban also causing significant reduction in the stroke. But the others, the reduction is much less pertinent as compared to warfarin. Not that they don't cause reduction, but they're not very much different from what warfarin does in terms of reduction. Now, as far as the major bleeding is concerned, this becomes a very, very critical issue because dabigatran 150 milligrams reduces strokes very significantly, but there is not much difference between the drug and warfarin as far as incidence of bleeds is concerned. Now, when you use lower doses of drugs, such as edoxaban 30 milligram or dabigatran 110, you have the reduction in strokes is equal to what you get with warfarin, not better than that. You have less bleeding, obviously, when you use lesser doses. With apixaban, however, there is a unique difference that there is not only significant reduction in strokes, but also a significant reduction in major bleeding as compared to warfarin based on standard doses of 5 milligrams to 2 times a day. Now, having known this for all these years, we still realize that as far as clinical practice is concerned, an unexpectedly large number of patients in clinical practice actually get reduced dose of NOACs, no matter which one we talk about, apixaban, rivaroxaban, dabigatran. There are patients who even get 75 milligrams 2 times a day of dabigatran for stroke prevention, for which we do not have any data to support. Normally, when would we recommend a reduction in dose of anticoagulants in atrial fibrillation? Primarily when we think that there is an increased predicted exposure and a related increase in the risk of bleeding in a given case, and that would normally depend upon age, the patient's body weight, and renal function. And if there is a history of previous bleeding, or if there is a high Has-Blood score that puts the patient to higher risk of bleeding. But we should also remember that adjusted dose, which is based upon the recommendations of the randomized controlled trials, is not low dose. So in Aristotle, for example, the dose of apixaban was reduced to 2.5 milligrams 2 times a day when 2 of the 3 criteria given were met. Age 80 or more, creatinine more than 1.5, and weight less than 60 kg. And one had to have 2 out of these 3 criteria to reduce the dose. But nevertheless, having reduced the dose in appropriate indication, you see that the benefit on reduction of stroke or systemic embolism is maintained. So is the benefit in terms of reduction in major bleeding that takes place. And similarly, in the Rocket AF, the dose was reduced to 15 milligrams per day when creatinine clearance was less than 50 ml per minute. And in that situation, again, you see that the benefits were maintained, similar to what one could see with 20 milligrams per day dose. Elderly form a very special group of individuals because they are vulnerable to bleeding, and that is there where we need to be much more careful. Here is the subgroup analysis of the RELY trial showing major bleeding in the key subgroups, dabigatran 110 and dabigatran 150 milligram versus warfarin on the right hand side. Now, overall, the bleeding is less with dabigatran 110 as compared to 150, that we know. But if we analyze these groups according to age, here is the three subgroups: age less than 65, between 65 and 74, and age more than 75. Now, there is a significant interaction as far as the age is concerned. The best benefits of both 110 and 150 milligrams are seen in patients who are less than 65 years of age. But then as age goes above 65, you see that these benefits are still there, but they become less than what you see in younger people. And as you cross 75, the benefit in 110 milligram in terms of comparison with warfarin is lost. And 150 milligram dabigatran actually causes slightly more bleeding as compared to warfarin in the elderly. And this is a very, very significant p-value as far as interaction is concerned. Now, looking at Aristotle, that gives us the subgroup analysis of apixaban. Again, less than 65 years, between 65 to less than 75, and 75 years and above. And you see here that no matter what the age, the benefits of apixaban are maintained as compared to warfarin in terms of causation of less bleeding. So therefore, according to the guidelines, it is recommended that the first choice in patients older than 75 years should be apixaban 5 milligrams two times a day, dose reduced to 2.5 milligram if two of the three criteria that we have discussed are met. Dabigatran 110 milligram 2 times a day would be the second choice. Rivaroxaban 20 milligrams, unless there is a reduced GFR, then in which case one has to reduce to 15. Now, what about those with a history of or at high risk of GI bleed? Because that is another very, very common problem. And here are the major SPAF trials, namely the data with dabigatran in RELY, the rivaroxaban here, and the apixaban, and dabigatran 110, dabigatran 150, and warfarin. Both 110 and 150 cause more GI bleeds as compared to warfarin, but the effect is more significant when you use 150 milligrams 2 times a day of dabigatran versus warfarin. Similarly, rivaroxaban 20 milligrams, the incidence of bleed in the GI is more as compared to warfarin. But as far as apixaban is concerned, numerically this is slightly less as compared to warfarin, though may not be statistically significant. Now, based on these, again, apixaban 5 milligrams 2 times a day or dabigatran 110 milligrams 2 times a day is recommended in those who have a high risk of GI bleed. But more important is that one should try to find out what is the cause of bleed, and if the patients are at high risk because of an H. pylori infection or something else. And as far as possible, one should try to treat that underlying cause. And should the patient actually bleed, one has to control that bleed, and then as soon as the gastroenterologist says that the GI bleeding has been controlled, at the earliest possible opportunity, one should start the oral anticoagulation again. Also, one should remember that the bleeding risk with dabigatran and rivaroxaban are dose dependent, and also the bleeding risk is more in patients who are more than 75 years of age. And another important thing is that whenever you have this, investigation should be performed to rule out a GI tract cancer, and that becomes absolutely important, both in the upper GI as well as in the lower GI. And lastly, I would like to talk about patients with chronic kidney disease, because they form a very significant subgroup of patients. And in spite of the guidelines, you can see here that in the real world, there is a significant number of patients who get inappropriate NOAC dosing. For example, in Orbit AF, dabigatran in patients with eGFR less than 30, where it is not recommended very freely, standard dose was used in more than 50% of the patients, and in eGFR more than 30, where dabigatran is recommended, reduced dose was used still in 11% of patients. In the Xanthus registry, which is with rivaroxaban, eGFR less than 50, where dose should be reduced, standard dose was used in 33% or more, and in EGFR more than 50, a significant 15% actually received the reduced dose. Now, overall, NOACs maintains similar efficacy and safety profiles in patients with or without renal impairment as far as reduction of stroke or systemic embolism is concerned. See, here is data with rivaroxaban and different levels of EGFR between 50 and 80, less than 50. And overall, here is dabigatran 110 compared with warfarin. Here is dabigatran 150 compared with warfarin, whereas with the other non-CKD patients, there is reduction in the incidence of stroke and systemic embolism. And similarly, that effect is maintained with apixaban. However, as far as the major bleeding is concerned, with rivaroxaban, no difference between rivaroxaban and warfarin. Dabigatran 110, mildly decreased renal function. The bleeding with dabigatran 110 is less than warfarin. But as you go to lower GFRs to less than 50, that benefit is lost. And similarly with dabigatran 150, no significant difference in terms of reduction in bleeding compared to warfarin, no matter what the GFR is, and that we all know from the RELY trial. The apixaban, on the other hand, seems to be safer in these patients and lower the GFR. That means in patients with less than 50, the reduction in bleeding as compared to warfarin is more as compared to those where the GFR is between 50 and 80. And this benefit is significant and maintained. So renal function, ladies and gentlemen, is an important component in dosing of NOACs. In normal dose is 5 milligram 2 times a day with apixaban, dose adjusted to 2.5 BID only if 2 of the 3 criteria are met, meaning thereby age more than 80, weight 60 kilograms or less, and serum creatinine of 1.5 milligrams or more, less than 15 ml per minute. We don't have very significant amount of data, although there is a lot of real world data of apixaban being used in patients on chronic hemodialysis as well, but no good randomized control trial. Dabigatran, again, creatinine clearance more than 30, 150 milligram is the dose, less than 30, we don't recommend it usually. Rivaroxaban, creatinine clearance more than 50, 20 milligrams, between 15 and 49, 15 milligrams per day. So in conclusion, ladies and gentlemen, I would like to say again that in general, there are no major differences in safety and efficacy between NOACs as far as stroke prevention in non-valvular atrial fibrillation is concerned in common garden variety of patients. However, in some clinical scenarios, particular drugs and or doses have to be prioritized, and that is primarily to balance the risk of prevention of stroke and the risk of bleeding. Thank you very much for your kind attention.
Over to Dr. Khalilullah, please. Dr. Khalilullah, you can unmute your speaker, please. Dr. Khalilullah.
Right.
Yes.
Can you hear me now?
Yes, sir. You can repeat.
Yes, it was a brilliant presentation.
Sir, your voice is not heard properly. No, sir. You'll have to unmute.
Is it better?
Very, very good, sir. You'll have to repeat what you started. Sir.
Okay. Thank you, Ulas, for inviting me. And in fact, it's a brilliant presentation by Dr. Sethi, as usual, on selection of NOAC and various subset of diseases, especially patients with renal dysfunction. I think we have a couple of questions, and I would like to hand over to my co-chairperson, Dr. Kannan, for some remarks on it. Dr. Kannan, please.
First of all, I would consider it a privilege to chair a session with Dr. Khalilullah. Thank you, sir. And I'd like to raise one more thing. There's one situation of labile INR values. We need an anticoagulant, and we have got labile INR. That group of patients also, this may be useful. This we have to consider NOACs. And once another situation in which we have to look for is the presence of a previous stroke. Patient has got a previous stroke, and then you're looking for an agent. And another situation is when you want to prevent a stroke. Prevent a stroke, dabigatran scores. But when prevention of recurrent stroke, apixaban and rivaroxaban score. These are situations which would just add on to Professor Sethi.
Yes, okay.
So, Dr. Elilan, please, you can.
Right. To Dr. Kamal Sethi, sir. As far as the efficacy for reduction of stroke, it is equal with all the drugs. It is only with the side effect there is some differences. Now, considering reversal agents, now for dabigatran we have idarucizumab, but whereas for others we don't have as of now. Will that influence your choice of NOAC?
See, as far as the need for reversal agent is concerned, this is often a talked about point, but in practical sense, how often have you really required a reversal agent? Most of the times, unless there is a very, very major bleeding or an acute emergency, which is a very, very small incidence, the need for reversal agent is rarely required. And most of these patients, the bleeding can be managed without the use of a reversal agent. And that's something, the clinicians are often very afraid of using the NOACs. And I would like to say this, that the serious bleeding, life-threatening bleeding is quite uncommon, although it happens. But if there is a high-risk patient, the clinician always has a choice to choose what he would like to choose. That one has to also see that when you give something to a large number of patients, what is the risk of bleed vis-a-vis the amount of benefit that you are getting. And that adequate balance has to be maintained. And the choice will always remain with the clinician who is treating the patient.
Dr. Elilan, you can take one question from the audience. Maybe you could be seeing that. I think Dr. Sethi had already addressed, but it could be repeated. It is something to a patient on hemodialysis or post-renal transplant.
Among the NOACs, one which can be taken with the lowest eGFR is apixaban, and one which causes lowest bleeding also is apixaban. So I would prefer in a patient with very low eGFR, of course, then 15 you have to use only warfarin. Till 15 maybe you can use apixaban.
There is a large body of real-world data available on patients having been given apixaban even when they are on chronic hemodialysis now, although we are awaiting randomized controlled trials. But I would make a small comment here that although strict criteria for dose reduction for apixaban have been given, the 2 out of 3, but the whatever pharmacokinetic and the dynamic data that is available in patients with poor renal function, the drug exposure is significantly high. So in a very low GFR situation, particularly, stage 5 renal failure, if I have to use apixaban, I would prefer to choose the lower dose, irrespective of whether more than one criteria for dose reduction is present or not.
Khalilullah sir, final comments.
I think looking at the price of the NOAC and availability in general, dabigatran seems to be available easily and affordable. If there is no significant difference in the side effect of these various NOACs, I think we should, in clinical practice, for you use dabigatran, but in some subsets of patients, in elderly patients, also in patients with chronic renal disease, one has to be very careful about the dosing. I think it is always a problem. It's always a problem in choosing these agents from one to other. But in diabetics with hypertension, CRF, you can't listen. You can't hear me.
No, we can. We can hear you, sir.
You can. Right. So in subset of patients, you have to be very careful about dosing, and also be careful that the concomitant medication should also be carefully selected before you administer them together.
So,
Dr.
thank
Sethi?
you.
Yes, sir. Very well said. The concomitant medication is extremely important, particularly when the patients are getting antiplatelet therapies. One has to be very, very careful. I have seen so many prescriptions where these NOACs are combined with aspirin or even with clopidogrel to some extent quite indiscriminately. And I would think that that is something one has to be very, very careful about.
Dr. Sethi, there's a request, and I like this question. I think even though you are exceeding your time, there's such a fantastic question which has not been addressed properly. There is no good answer, but you are the best brain to hypothesize what could be the answer for Dr. Sheikh Mohammed Tahir's question. How can NOACs prevent major bleeds and at the same time provide better anticoagulation? Please give us the biological explanation. Is one of the fantastic questions debated.
I don't think there is a data available to answer that question, and unless there is real data available at the molecular level and the cell wall characteristics, etc., in these patients, it is not possible. But one is not saying that they prevent bleeds. All of them cause bleeds, but the incidence of bleed is less with some as compared to the others in similar group of patients, because these are all randomized control trials comparing warfarin. And there is no head-to-head comparison between NOACs X and NOACs Y, and none is likely to come in future because is going to take the risk of doing that. So this is absolutely conjectural because this is not head-to-head comparison. For example, the comparison only with warfarin is there. And that is true in all subsets of patients, including the most recent trials that address the patients who have undergone PCI, for acute coronary syndromes where triple therapies used to be recommended, etc., etc.
All right, sir. Dr. Sethi, sir, thank you very, very much. I think that was a fantastic question. And the very purpose of holding this kind of a digital summit or a conference is to just to raise these questions. And I think everybody did a great justice to this topic. Several times it has been addressed, but sir, you did a great job and the audience put up some real interesting questions. Sir, with your permission, shall I go to the next session, which is going to be the last session of the day? And this is something to do with an important device issue, namely the CRT issues. We know that we have some non-responder issues with the CRT, and the expert in the country regarding the devices, if you ask me, is the speaker today, and that is Dr. Balbir Singh. Who is going to be talking, probably he's going to be demonstrating a case of converting a non-responder to responder in a case of CRT, and it's going to be moderated by Dr. Amaya and Dr. Ramakumar. Amaya and Ramkumar. Ramaya had been with us. Now he's one of the famous electrophysiologists in Mumbai. Ramkumar is with us at MMM. He is one of the experts in the device implantation and its follow-up, and particularly in echocardiography. So over to Dr. Amaya to invite Dr. Balbir Singh and Dr. Ramkumar to be co-moderating. Thank you. And over to you.
Yeah, good evening, sir. I hope you can hear me.
Very well. Very well.
So the talk is to be given by Dr. Balbir Singh. Sir needs no introduction. He has been the former president of the Indian Heart Rhythm Society and also an Padma Shri awardee. Currently, Sir is the chairman at the Max Heart Healthcare Unit at Delhi. And he will be speaking to us on a case of converting a non-responder to a responder in a case of CRT. With me, the chairperson is going to be Dr. Ram Kumar, who is also my colleague from Madras Medical Mission. We work together at Madras Medical Mission. So I invite Sir Dr. Balbir Singh for starting this session.
Thank you, Dr. Amaya, Dr. Ram Kumar. Ullas, it's nice to see you there with a different look now. And at least I've been able to see you for up to 6 months or so. So can I have my video started because it says the host has stopped the video.
Oh, really?
So if somebody...
Your slide is seen.
Okay, then I'll now start my presentation. And
yes, you are seen. Yes.
So CRT non-response is a big issue because I'm going to show you why and how. So 1/3 of patients who have class 1 indications of CRT, we are not talking of patients who did not have a class 1 indication, will have non-response. This is from Miracle ICT, InSync trial, Prospect, Freedom. So this is very clear that 1/3 will not get the response despite having been chosen well. This adds to huge costs, huge dissatisfaction on the families that spend money. So we have to understand which are the patients. First is, how do we define a non-responder? This is very confusing, a very, very controversial thing. We know of a lot of patients where they see a clinical response, but we don't see an echo response. The family is happy that you've got something quality of life improvement, but you did not get the LV response. So I'm not satisfied because I did not remodel the ventricle, but the patient's symptoms did improve. This is generally patients who are end-stage heart disease, and we're just trying it as a last ditch stand. That is my experience on this, that we improve clinical symptoms, do not improve LV response. So there's a conflict. Then if we look at the responders and non-responders and negative responders, we have people who are negative responders. That means the end systolic volume actually increases. These are generally who have been not selected properly. So you can see that negative responders have the worst outcome compared to the non-responders, compared to responders and super responders. So the responders and super responders do the best, as you can see already, but the negative responders, they have very, very short problem, a very high short-term mortality. So what is the agreement on the current definition? So we are a part of InSync, and I'm a part of the steering committee, and we had a lot of problems trying to sort this out. And I remember having the biggest people on the globe discussing this out and trying to. So finally, we arrived at this end systolic volume greater than fall in end systolic volume greater than 15%. We forgot about ejection fraction because we thought it was dependent on many factors. And one person may say 5%, one person may say 10%. So we said, let's hold on to one, which is fall in end systolic volume. So you could see there are so many definitions of a responder in the echo definition itself. Again, the clinical definition again varies a lot. And again, a 6-minute walk test is what we thought was the best criteria to decide the responder and non-responder, because this NYHA class can be very subjective. We wanted an objective parameter, so we added 6-minute walk test. But you can see so many people have different definitions in their non-responder. So we come to the same conclusion that we have 70% who are responding and 1/3 do not respond. So when is the time to call it a day? That when will you say this is a responder and this is non-responder? How much time should you wait? So 6 months has been what was thought of. We were a part of MPP trial, and I had the good fortune of having had discussed with Professor Christopher Lerck this problem in the MPP trial, because we waited some patients for 1 year who were not an MPP, and they started showing response. So practically, I think waiting for 1 year, not 6 months, is when you should call a responder or a non-responder. Don't be in a hurry at 6 months to say, oh, this non-responder, forget about it. Maybe 1 year is the right time to call it today. So response is dependent on many factors, as you can see. The first and foremost is the ECG. I think there cannot be a better judge of a response than a better ECG. There could be mechanical factors such as a large transmural scar in the lateral wall, mitral regurgitation. There could be biological factors. We know female gender does very well. We know non-ischemic cardiomyopathy does much better than ischemic cardiomyopathy. And we know there are some hereditary and calcium handling properties which could also address this response. But by and large, if you look at this graph, we know that the wider the QRS, left bundle branch block, females and non-ischemic cardiomyopathy do the best. Narrow QRS, non-left bundle branch block do the worst. Now, what are the causes of non-responder? Suboptimal AV interval is the commonest cause. And we got some very good information from the InSync trial, which is on that how InSync devices from Abbott do this optimization optimally and dynamically, and they do it quite well. We more often think of suboptimal lead position, but it is lower down. We have arrhythmias which forbid pacing, like PVCs, like atrial fibrillation, which make it difficult. Anemia above suboptimal LV lead position. Less than 90% BIV pacing is another cause for non-responders. So we have pre-implant assessment, lead placement, timings, which all help electrophysiologists to improve the response. A non-responder we have to tailor, optimize, and see what we can do for that particular patient. These are very elegant diagrams to show that if you select the latest activation on whatever system you do, Ullas does a lot of 3D mapping with these devices. I saw his paper, but just the simple parameters like the QLV we found was an excellent way to decide which lead and where to place. And it really helps a lot. You can't be performing 3D mapping in a already complicated patient who's quite sick. And but these help us to understand, clearly help us understand which vein. That means every vein has a different kind of activation. Like, for example, this vein had the latest, and it was anterolateral vein. This was the lower lateral vein, which had the latest activation. This did not have any good vein with late activation, and response is not going to be good. And all these QRSs were the same. So you have to select your lead well. So we have seen that LBB are not all same. If I find notching a lead 1 and AVL and B5, V6, I'm very, very happy. And I know of patients who had QRS just on borderline 130, but they had the notching. And we got a good response in those patients. And there have been patients who are 140 plus, and we did not have that notching, looked like LBBB, but did not get a good response. So this notching is very, very good because it tells us it's a true LBBB. Now, we also understand the three big factors: the QRS duration, the QRS morphology, and etiology. Non-ischemic cardiomyopathy, the highest likelihood. Other factors are the septal rebound stretch, which many echocardiographers tell you, many don't. Dysynchrony is very, very vague. It's totally in the hand of the echocardiographer. But posterolateral scar, yes, it's a very good predictor. If you have absent, you would have a good response. So, CRT is improving, better patient selection, attention to optimal lead placement, as I said, basal to mid-LV region, QLV, better technology, quadripolar lead, optimal programming like the AV interval, optimization of algorithms. What are the troubleshootings? The medication, is the LV lead in proper position? We're going to show you a case of that kind. Are there any comorbidities? Is the BIV pacing more than 90%? Does the patient need optimization of AV or VV timing? So the implant issues are LV lead optimal position is not always possible. There are sometimes high pressing thresholds in one vein which you overcome in another vein. There are phrenic nerve issues, and quadripolar lead helps us in many patients. Two reasons why it is more useful is that you can, like for example, this is a bipolar lead. This has been placed right at the apex. You want the lead to pace somewhere here. You can place a quadripolar lead all the way down and pace from the basal segment and get a good response, because pacing from mid and basal segments is much better than pacing from the apical segment. So the quadripolar can do that job for you. So response depends on device optimization, patient optimization, and typing optimization. This is suboptimal AV delay, which I said was the most important criteria. And we have many studies to show that. So how do we measure? We can measure from the sensed RA to LA activation, or we can measure from the paced atrial to the ventricular activation. We need a dynamic AV interval because AV interval changes with exercise, with movement. We have two algorithms. One is the adaptive CRT and one is the in-sync, which we are testing to help us reduce the AV delay when you want to do it. Let's look at the sync AV dynamically. Now in sync AV, what is done is that this is a triple fusion, a fusion between the impulse coming down from here and the two impulses coming from the ventricle and the left ventricle. So there's a fusion here. If you fuse this by changing the optimal AV delay, you can narrow the QRS in many patients to less than 120 milliseconds. And we have done that and shown it. And we have gone up to a sync of -80. That means -80 of the natural PR interval. You can go down to that and achieve a very good result. And the study that we are doing is a global in-sync registry, which is a very, very interesting study. If we do the optimization of AV intervals, we can reduce the QRS duration significantly. And if you add multi-point pacing, you can sometimes even get even lower QRS. So as most of us now believe that QRS duration is one of the most important predictors of our response. So newer algorithms will help to reduce the chance. The multi-point pacing, what we are still looking at the data, is not seemingly as exciting as what we thought at one point of time. There are two reasons for that. Getting pacing from all the four poles doesn't happen in all patients. In fact, significantly, more than half, you could get good thresholds in all. In some, there's distal phrenic nerve stimulation. So how to get thresholds in all four is very challenging. It's not as easy as thought that if you put a quadripolar lead, we'll get threshold all along. You don't get it. So this is a very challenging thing. We still do not have an answer, but surely in patients where you get multi-point pacing, you get the QRS to narrow further down. As you can see in this diagram, you can get the QRS to really narrow when you put the multi-pacing on. So the results are still not out of the MPP trial, but we'll get some answers from this for sure. So now let's look at something, the case that I wanted to show. This is all to briefly tell you what I had just tried to tell you, that we should try to achieve 100% of pacing as far as possible, particularly in patients who have atrial fibrillation. Now, atrial fibrillation in patient has permanent or long-standing persistent. Most of us would like to do an AV nodal ablation after the CRT has been implanted for a month or so. And this data is very convincing that patients, if you don't do it, majority will not get the good response. And this paper comes from Gasparini, who clearly showed that AV nodal ablation is a very useful sign. Now, having discussed all this, let's go to a case study. This was a patient who came to us in a complete lockdown and this was in March last week when there was strict lockdown. She came in.
Interruption, sir. There are 2 minutes for your screen time left. Thank you.
So this patient came.
Balbir, you can take some 5 minutes. Go ahead, please.
So this patient came in severe heart failure on inotropes, referred from another institute. She had a CHB in 2015. It was a non-ischemic CHB. At that time, the ejection fraction was 45%. Coronaries were tested and were normal. So if we look at the block CHF trial, we know that 45% may have got a CRT at that time, but I won't question that a DDR pacemaker was implanted and she was 100% dependent on this pacemaker. In 2018, her EF dropped to 30% and it was upgraded to a CRT. In fact, it was not upgraded, but a CRT was implanted from the left side. It was an Amplia MRI, and the right-sided pacemaker was turned to an ODO mode. She continued to worsen. In fact, she was a negative responder. As you can see, her ejection fraction started worsening, and she clearly told us that the CRTD made her worse than what she was. And we can clearly see she was a negative responder with a marked disc synchrony that was seen. This was the ECG, and you can clearly see that this is in an anterior interventricular vein. We have positive 2-3 AVF. QRS is still not as narrow as what you would like to see, and she's 67 years old, and negative lead 1 tells you it's an LV pacing on the lateral side clearly, and we knew from the X-ray that this was anterior vein. I'm sorry for this X-ray, but at least this tells you this is a CRTD. This has a quadripolar LV lead, a DF4 RV lead, and a double chamber leads the atria and ventricle. The ventricle lead was at the apex of both the CRTD and the pacemaker. This was in the anterior interventricular vein. So this was not an excellent position of the vein. And so we can say that non-ischemic cardiomyopathy, complete heart block, non-responder. What should we do? It was a very difficult question. Should I put in another LV lead in a better position? Was question number 1. Shall I put his bundle lead where do I put it? I can't put it on the CRTD side. She had a quadripolar catheter on the LV. So how do I put a his bundle lead with a quadri LV? And RV is a DF4 connector. I can't do that. So I decided that I will put a physiological pacing lead on the right side and connect it to the double chamber pacemaker on the RV port. So we used his bundle pacing lead using a select secure lead 3830 with a sheath. And the lead was connected to the RV port of dual chamber pacemaker while preserving the previous RV apical lead, which was capped. This was the pacing from the left bundle area. You can see the QRS is much more narrow than what you saw. You see a terminal R wave telling you that we have in the left bundle area. You see a negative 3 and AVF because when you are in the bundle, the activation goes down right to the apex of the RV, and you get this kind of a complex on 2,3 AVF. So this was pacing from the left bundle area. The QRS was 129. At this stage, I thought we have an amplia on the left side. Let's try to fuse these two impulses. Let's let the amplia think that there is an RV impulse coming, and it paces the left ventricle, trying to fuse with the right ventricle impulse. So this is the fusion, which is called the hot CRT, fusion between the LV pacing and the his bundle lead or the left bundle area pacing, almost making the QRS normal. So this was accepted to me, and we looked on. This was now what it was: 2 RV apical leads in the anterior interventricular lead. Here is we come with the left bundle pacing lead on from the right side, and this is how it was connected. You see the sheath on the septum, and you see the left bundle lead screwed into the LBC. So left-sided pacemaker DDD with a sensed AV delay of 90 millisecond, paced of 110, and the left device was kept on adapt CRT on. It would sense the right pacemaker and pace the left ventricle, and this resulted in a beautiful fusion. This is just to show what an amplia can do when there is an AV block. It does BiV pacing, and here the BiV pacing was not the pace to the CRT, to the amplia. It was no AV block because it was getting an RV sensed paced beat from the right pacemaker and then giving an LV pace. So there was a fusion between these two pacemakers. And this is what we saw on echo. You see the dysynchrony has gone. This is the lead at the center. This is the left bundle lead. Right in the center, you can see just jutting out is the left ventricle. And see the dysynchrony is gone. The ventricle improved, and so did the. So key learnings and take-home message from this is that CRT non-responder is a big issue. 1/3 will not respond. ECG is the key to understand. Optimizing AV delays, VV delays are key to understand that you can actually try and narrow the QRS and use this to main. And hot CRT study from Vijay Raman is a very interesting study and may add to value in many of these non-responders. Thank you very much for your patience, and thank you, Ulas, for giving me 2 minutes extra.
Great. Over to Amaya and Ram Kumar, please.
Yeah, that was a very erudite presentation, sir. And I think I don't have access to the questions here.
Okay. There are no questions presently coming up. I know they are screening, but I just was wondering, don't you think, Amaya, this could be the only case in the literature where you made use of bilateral devices?
It's almost like a multi-site pacing, but the very fact that the patient has shown such a good improvement.
Balbir, is this the first ever case to be reported?
Yeah, I have not read anything of that. I don't think there can be another case, but we used our mind because I couldn't have used a bipolar lead on the CRT. It had a DF4 connector and a LV quadripolar lead. So there was no way that I could have used a bipolar lead. And I didn't want to use another LV lead because I was not sure if I get a good vein or not.
Fantastic.
Just for the purposes of revision for the delegates, I would just ask a question. When a patient comes to the OPD for follow-up, which are the most important parameters you would like for them to see and program in the device so that the optimal rate of pacing increases or the optimal therapy improves?
Okay, so when the patient comes to the OPD, what we do is at discharge and at 1 month, we connect the ECG machine, have a 12-lead ECG, try to program to get the narrowest QRS. This is the best way to optimize the AV delay. People have said echo, but I think QRS monitoring with ECG is the best parameter to select in AV delay. You could also do VVV testing at this stage. So suppose you're not able to get a good QRS with AV optimization, you can go to the VV delay and see where you get the best QRS. You have to have what is the best ECG actually to predict a response? So there's a beautiful paper from the Cleveland group, which says that there's a type 2 ECG change. You have a small R wave in V1 and then a big S wave. So there are 3 patterns that you can get on V1. Predominantly negative S wave, a small R wave followed by an S wave, or a predominantly R wave. The type 2 pattern, where there's a small R wave, then an S wave with a narrow QRS, is the best pattern to predict success. So you have to have an ECG to do this. And in our practice, device check is generally done by a technician, but we always get an ECG when the patient comes, particularly if he's feeling breathless. We will definitely get an ECG because you'll get the maximum clues of how he's going to do on the ECG.
I would invite my co-chair to ask some questions.
Ram Kumar, yes. Go ahead.
Yeah. So it's a very wonderful presentation from Dr. Balbir Singh. So it's a very complex case, but the end result was very beautiful. Such a narrow QRS, so definitely will be from the cath lab, we will come out happily. Then definitely it will be a good responder. So with respect to the echocardiography, as Sir said, in an OPD, whenever the patient comes to us with breathlessness, the most usual thing we see is the E by A separation in the diastolic mitral flow. So we try to adjust with the AV delays with the programmer, another thing. But most of the time we may be able to achieve it little bit, but we will not be able to get the symptoms completely knocked out. So even by E by A separation with AV delay adjustment is a very difficult job. So some patients we are lucky to get it done, but some of the patients we are not able to get. But as I said, the ECG criteria are very, very vital. Take a regular ECGs, adjust the AV delays, adjust the VV delays, get the ECG narrowed down with these things. And after that, you see the E by A. If the E by A gets separated, I feel happy. So retrospectively, I go the E by E. I first see the ECG, then go by the E by A separation, I feel happy. So rather than E by A first and going for looking the narrowness.
I had a question, sir. Regarding this software algorithms like adaptive CRT or sync AV, they normally suggest some parameters to be programmed, which according to them would give you the best response. But when you see that on the ECG, you don't feel that the ECG response is so great. So
right. So Dr. Meya, I will answer that question. Very important question. So I was part of the ADAPT CRT and a part of now the InSync programming. So we had the maximum number of patients in the ADAPT CRT. And after that, we were stopped to do because there were no differences in our group. So the investigators wanted to show some differences in which has not happened because we know the follow-up didn't show much. And it was programmed to the nominal readings. So there was no echo or no ECG done to program these ECGs. So when we went to InSync, now I'm the part of the steering committee, we decided that it has to be ECG-based programming. So the InSync study is you have to program AV delay and VV delay to get the narrowest QRS. And that is where you will leave the patient. And on follow-up, you will take an ECG to see if the QRS is widening or not. Because I think most of us do feel that there is a very good correlation between narrowing of QRS and the response.
But Amaya, I think you can read a question. I think it's an important question there from Murugarajan Singaram.
Yes. What should be the approach for patients with reduced ejection fraction with left bundle branch block with RV dysfunction? Will CRT play a role?
Right. So it is the level of RV dysfunction. If you get a patient who's got clear right-sided heart failure, JVP enlarged, liver enlarged, got cross period edema, best is to put the patient on diuretics, see the response, because RV can remodel in many patients once you give a good diuretic therapy. If you take such a patient straight away for CRT, the response may be extremely poor. But RV dysfunction and gross right heart failure are poor predictors. As Wellen said, that if you have AVR positive in a patient who has LBBB, it's a clear sign of RV dysfunction, and most of these patients do not respond. So similarly, if you have such a big right ventricle that produces R wave in AVR, they are likely to be. So our policy is to diurize them well, repeat an echo to see how the RV function has behaved. And many of them, when the PA pressure comes, the RV function improves and they become candidates for CRT.
All right. So thank you, Amaya. You have any more comments to make, Amaya?
No, nothing. Thank you.
So thank you, Amaya, Ramkumar, and Balbir. That was one of the fantastic cases. I don't think there is any other way you could have converted that non-responder or negative responder to such great positive responder. You have done a great justice, Balbir, and we are honored to have you.
Thank you.
Ladies and gentlemen, we are coming to the end of the 4th day of this Cardiac Rhythm Council meeting. It has been a pleasure to have you all and illustrious speakers and moderators today. And that could be the reason why we have got the statistics here, which is very pleasing. It is more than 800 people who have registered, and at any time the active participants are touching around 300. I think it's a great session for the day, and I thank you all once again, and I wish you a good night. Thank you and bye bye. And we are going to log in tomorrow again by 6:30 for the day 5th of this Cardiac Rhythm Council meeting. Bye bye, everybody.